Welcome to another episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor. Welcome back, everybody, again to another episode of the show, bringing another really fascinating guest for you today. On the show today, we have the honor of being joined by Dr. Paul Burton, Senior Vice President and Chief Medical Officer at Amgen. And Dr. Burton has built one of the most remarkable careers in modern medicine and biotech. After initially training as a physician and cardiovascular surgeon in the UK and earning his Ph.D. in both molecular and cellular biology at Imperial College London, he transitioned into the biotech industry. He spent over 2 decades leading the development of innovative medicines across cardiovascular disease, oncology, infectious disease, as well as metabolic disorders. Prior to Amgen, Dr. Burton served as Chief Medical Officer at Moderna during one of their most consequential periods in modern public health, overseeing both medical strategy, pharmacovigilance, and prior to that, 16 years at J&J, ultimately serving as their Chief Global Medical Affairs Officer, overseeing not just medicines, but also digital medicine initiatives, collaborations in the area of virtual clinical trials. And today, Dr. Burton leads Amgen's worldwide medical organization, helping guide breakthroughs across a very broad research portfolio. And one of those efforts that we're really going to be diving deep into today is Amgen's work targeting lipoprotein A, or Lp(a), as it's most commonly known. This genetically inherited cardiovascular risk factor affects one in five people worldwide, and we're going to be discussing their small interfering RNA therapy, their clinical programs, and ultimately looking to answer the big questions about how this is going to ultimately not just lower LPA, but prevent heart attacks and strokes. And we're going to be exploring everything from Dr. Burton's career, what it means to lead medical strategy at a company like Amgen, and ultimately what the next decade holds for the future of cardiovascular disease prevention. A lot to get into. Honor to have Dr. Paul Burton. Welcome to our show.
Hi, Ira. Thank you for that. Privileged to be here. Thank you so much.
No, I'm really privileged to have you today on the show, Paul. I'm really looking forward to this discussion. Before we go down the Lp(a) path, I mean, I'd like to spend a little time on a couple of the earlier chapters of your career, because they build a very interesting path in terms of where we're going to be going. And, I've listened to you on previous shows talk about how your grandmother's illness not just influenced you in becoming a cardiac surgeon, but also, your dissertation work was on, cardiac cell cycle and regenerative biology and all these very interesting themes in 2026, which are quite hot in terms of cardiac regeneration research. Take us back a little bit, Paul, if you would, and just tell us the beginning of this really interesting journey you've been on.
Yeah. It's an interesting thing, Ira. If you work on something for long enough, it kind of comes around, and become topical again. No, as you said, I always wanted to be a physician. As a little kid, I wanted to be a physician. Finally went to medical school, qualified, and I liked intensive care medicine, and I kind of enjoyed doing that, and I wanted to be a surgeon. And so, really having that opportunity to bring the two together for me was cardiothoracic surgery. And so I did basic surgical training, and then I had an opportunity to do a PhD in the lab of, really one of the most, I think, innovative physician scientists around. This was back in the 1990s, a man called Magdi Yacoub. Magdi is an Egyptian cardiac surgeon who went to the UK and really revolutionized the idea of transplantation kind of pioneered heart and lung transplantation, built up the center there that I was part of, really as the largest volume cardiothoracic transplant center in the world at that time. And Magdi was an amazing man. He was an amazing physician scientist, and I just, was inspired by him. And so I did a PhD in his lab. And there's a couple of interesting things. I was training to be a cardiac surgeon, and a lot of the patients that we saw had heart failure, and you try and treat them with therapies or with surgery. But the interesting thing about the heart is that the heart is made of cardiac myocytes, cells that kind of like join together. They're able to conduct electrical impulses and obviously allow our hearts to beat. But the cardiac myocytes that you and I have now are the ones that we were born with. They really don't ever divide, unlike cells in your gut, our skin cells, cells all over the place that divide. We get rid of them and new ones come along. And that is the problem that underpins heart failure. That people typically have a heart attack or something happens to their heart, those heart cells die, and there isn't an opportunity, to replace them because they don't just divide again. And so the heart kind of starts to go into heart failure over time. And that was why I did, as you said, some of the work in my PhD thesis.
It's quite interesting because following your dissertation and you move into biotech and your publications here, and you publish quite extensively, as you're mentioning, on heart failure, translational clinical cardiology. Then the themes of inflammatory mechanisms, the neurohormonal pathology. We start seeing, alpha-2 necrosis factor, IL-18, a lot of the pro-inflammatory cytokines, and obviously your work transitions from developmental biology to this, this systems biology perspective on, hey, there's a lot more going on here than just this heart being a pump and cholesterol floating around. There's quite a complex biology happening here, and obviously this is going to lead into in a little bit LP little a and some of the other things that we're learning about biomarkers that maybe we found 60 years ago that are coming to prominence now. But talk a little bit about this era as well. I think it's
Yeah.
kind of important.
Yeah. So it was a very interesting way, actually, that I started up that work while I was still in academic medicine in the UK. So as I mentioned, I worked for Professor Yacoub, one of the largest transplant centers in the world. And one day, he said, hey, we do a lot of transplant retrievals. Now, clearly, those patients were brain dead. Something had happened to them. Their heart was still beating, but they were never going to regain consciousness. And, that whole process, brain death in organ donors, is, a massive insult to your whole immune system, your hormonal system. It's this massive, massive thing that happens. And so we started up a program where I would actually go out to retrieve these donor hearts and would use an echocardiogram. I took out a portable echocardiogram and I would do a transesophageal echo on these patients. And we found that probably, at least 20% of the donors had really poor functioning heart performance. So they were kind of in acute heart failure. And they were in acute heart failure because they were brain dead and they had had this cytokine storm, let's call it, and this hormonal storm going on that was causing their heart just not to function. So the big question was, well, could you do something to reverse it? And there have been agents, there are now efforts today that kind of like let you try and resuscitate those patients for perhaps 6, 12 hours before you're going to take the heart so that you can improve the heart function. But what was very interesting at the time was we would be able to maybe take some of the blood from those donors, even if the hearts were functioning so poorly that they couldn't be used for transplant. And when you assayed the blood, they had sky-high levels of inflammatory mediators. IL-18, you mentioned it, TNF alpha. They really looked like they were in septic shock. In many ways, if you fast forward 20, 25 years, they actually looked a lot like people who we saw in intensive care units suffering from, really severe sepsis because of COVID. So I think, there is a connection, which is that the heart cells that you are born with are the ones that you die with. They don't replicate over time. They're very fragile. And in certain clinical settings, like intense inflammation, terrible situations like brain death, like overwhelming sepsis due to viral illnesses or whatever, that our bodies produce this environment, hormonal changes, cytokine changes, inflammatory changes that happen really, really quickly and negatively impact the function of the heart. And it can go from being perfectly functional in a young person one moment to really being in acute heart failure the next. So that for me sparked this idea of could you do something about that? And right at that time, so this is end of the 1990s into 2000s, there was a company in Seattle called Immunex. And
Yep.
Immunex had invented Enbrel, TNF
Yep.
alpha antagonist, right? That they had actually tried to take into heart failure because there was this whole growing body of evidence that heart failure was driven in part by inflammatory mediators. And so one minute I was training to be a surgeon in the UK. I had done my PhD and I saw this job advertised at Immunex in Seattle um, to go and help, do research in heart failure and in arterial wall inflammation, atherosclerosis. And I felt like, well, I've kind of been trained for this. I've been working on this area. And so my wife and we went over to Seattle, uh, beautiful, amazing city, and I got offered this job. And so I left the UK. We were a lot younger, a lot more uh, foolhardy probably, and got offered this role to go and join industry at Immunex in Seattle, and that's what I did. And so I spent basically the first year trying to recapitulate that kind of model. Like, how can you
Hmm.
get models of heart failure,
Yep.
which are inflammatory driven? Because Immunex was all about inflammation, cytokines, and trying to then block that or use it to our therapeutic advantage. And they had this whole slew of different medicines that you could modulate the inflammatory cascade with. And so I did that for some period of time, and I learned a lot. It was a great entry into industry. And then just about a year after I joined, we were acquired by Amgen.
Yep.
And so I actually ended up then being moved into clinical development at Amgen. Had to leave Seattle and we went to Southern California. But it was a time in my life when I could suddenly see this connection between basic translational research and trying to bring about, a therapeutic intervention. And I think for many people like me who think about going into industry, or should I stay in clinical medicine? Do I stay as a basic science researcher? What do I do? For me, it's cemented this idea that you can translate from the bedside to the bench and back with a therapeutic. Kind of sounds a little bit cliched today, but that really is, I think, what we can do.
Hmm.
But it's a partnership. I've learned that over my now, 25 some years, that industry, academia, even governments certainly learned that during the pandemic. If we work together with a shared purpose and that maniacal focus that we all, can bring together, there's really nothing you can't do. So it was an amazing sort of testing ground, I think, in my career that solidified for me the benefit of what you can do with amazing medicines. If you have focus, drive, and organizations behind you that want to achieve these things.
Hmm. And there's the obviously the bench, the bedside, and then many bedsides, and clearly, when we're talking about things like you're mentioning, whether they're pro-inflammatory cytokines or neurohormonal dynamics or lipids, which we'll be getting to shortly, cardiovascular disease, still the mother of all public health issues. And we
Yeah.
talk about how many people don't have hypertension under control nowadays in 2026, who don't know about the status of cholesterol and LDL and all that. Say just a couple words while we're on this, and then I'll promise you we'll get to Amgen after this. Talk a little about your population health initiatives, because here, obviously both at J&J, when you were working on the digital health stuff, the collaboration with Apple and all that, and then obviously at Moderna, because you're in the thick of it, you had to think about everyone on the planet, pretty much. Really big picture here. Say a few words about this as well, because these are not small indications we're talking about.
Yeah. So, again, they were amazing opportunities that I really do feel privileged to have been able to be part of. The work at J&J with Apple, a study called Heartline, basically aimed to, this is back, we're starting this pre-pandemic, so, 2018, 19. The idea was, can you bring people into a platform, use a technology like an Apple Watch, and use it to then try and detect atrial fibrillation? And if you can do that, can you funnel people to care and improve their clinical outcome? And we were able to, stand that study up, enrolled thousands and thousands of people, and it did that really quickly. We were able to do another study in heart failure called Chief HF, much
Hmm.
smaller, but also launched right at the start of the pandemic, but was able to enroll people in a very decentralized, pragmatic way. We know today that in this country, 70% of people live more than 2 hours from a major academic medical center, a clinical trial center. And that's been constant. It's not changing. So how do you democratize clinical research? How do you manage to do, really impactful, important clinical research, but involve people in underserved communities as well? How can you do that? I think you do it through digital medicine, and
Hmm.
maybe let's get artificial intelligence. Let's say talk about it here and not again during the thing.
Sure.
But look, people today, whether you're a patient or a physician, are looking to get information about their disease, to be shepherded down their disease journey in very, very different ways than they even were 10 years ago. I mean, when we started this idea of Heartline, it was about, can you have a wearable, and can that somehow help you manage diagnosis of a disease and funneling to care? Well, now you just have to turn on your computer and go onto your large language model of choice, and you can get massive amounts of data. You can put in your own personal results right into that. You can show it. Here's my CT scan, the report. Here are my blood results. And it will give you some pretty accurate information. So, the world is changing, Ira, in a way that I think is for the better,
Hmm.
to be able to accurately diagnose people. That's the number one thing that physicians need to do. And honestly, it can take a long time to do. Make a diagnosis, give people some treatment options, and then help them get to their treatment. I think, all of this work I did, whether it was around digital medicine now as we do more and more around artificial intelligence, I think will only help there. There is a 20-year-old statistic that came from the Milken Institute that, again, in this country, only about 1 in 10 people have health literacy sufficient to allow them to navigate the healthcare system. And that's 20 years ago. I would argue, if you did that survey again, that it's probably worse than 1 in 10. So I think it's very hard for people to navigate the healthcare system, hard to get a diagnosis, hard to really work out, okay, what are my treatment choices now? What should I do? So I think the world that we're entering, while it's moving very fast and AI is clearly bringing a lot of churn with it, and we've got to work through a lot of stuff, I think it will have very beneficial impact on how people manage their disease journey and get to the right treatment.
Absolutely. Absolutely. So that brings us to Amgen again, and you joined the company again back in 2023, Chief Medical Officer. Let's say a couple words, or I think of this just to talk about what that means, what your current roles and responsibilities are. As you know, Amgen is not just a cardiometabolic company. We profiled, your colleagues, Angela Cox and Ryan Potts, talking about hematology, oncology, and bispecific T cell engagers. You're in bone health, you're in rare diseases. What's
Yeah.
your typical day like? 'Cause obviously think a lot more about more than cardiovascular medicine, but take us into the day of
Yeah. Yeah.
Burton, if you would.
So as you say, I rejoined Amgen in 2023, um, coming from Moderna. So, the world was really kind of like digging out from the pandemic. It
Right.
was a different time. And I came in leading medical affairs, regulatory affairs, and global clinical safety. I now have a focus on medical affairs. We've stood up a digital medicine organization. We also have a group called Inclusive Global Health and Impact, which is really global public health. How do we bring our medicines to underserved communities here in the US, around the world? How do we think about what those patients need and help meet those needs? So a typical day, I think now as you become more senior in your career, what happens is you get asked about a problem. I spend a lot of the meetings I'm in today are, hey, there's this problem or this issue we've been thinking through. We've got some ideas. How do we come up with a solution? So I spend a lot of time on that. Spend a lot of time thinking about how do we translate data into knowledge. Data are a string of ones and zeros. We produce a huge amount of data across our enterprise. As you say, we're in multiple different therapeutic areas, biosimilar medicines as well. So we produce huge amounts of data. But and I read something a while ago, we're drowning in data, we're starving for knowledge. I think that is true in the healthcare system today. Systems, physicians, patients even want to know, okay, how do I take that piece of data and fit it into a treatment paradigm? When do I start this medicine? What do I do if I worsen? What do I do if I get better? And so trying to help physicians and patients and systems kind of think through that, manage our medicines in that setting is really what we as a team spend a lot of time on. The opportunity for digital medicine as well is huge. Again, can you democratize clinical research? Can you speed it up? It may not be that you can do an early stage clinical trial when you're just testing out a medicine in people. But as you move down that clinical development pathway, as you get into later phases of development, doing digital medicine, being able to decentralize it, is a great way again to democratize it, to speed it up, to do it cost efficiently. So thinking about all of that is how mostly I spend my days.
Awesome. So that being said, and a little background story here. So last year, like I guess a lot of people, I see a commercial on TV for something called LP little a. I go to my doctor for my next checkup. I said, put that on the list of stuff that we'll look for. He says, fine. It comes back. It's slightly elevated. I said, what do we do? He says, just keep taking your statin. And when there's LP little a drugs out there, we'll worry about it. Take a little time, Paul. Introduce our audience to LP little a.
Mm.
It's something that I was surprised that it was discovered back in 1963. Several years before I was born. So we've known about it for a while. Take us into what it is, why it matters in cardiovascular disease, and coming back to everything you know about atherosclerosis, of inflammation, of
Yeah,
thrombosis, and why, if 1 in 5 people in the worldwide have sort of an elevated level of this today, has it been kind of overlooked since
yeah.
1963?
Okay. So that's a big topic, Ira. Can we let me step back even more? Let's just talk
Not
about
back.
fat and LDL cholesterol for a minute, okay? Because I think really in many ways the story starts there. Look, we all take in fat, right, in some way or other as part of our diet. And fat is broken down in your gut, and we mostly use it for energy production. Okay. And so we burn fat in, muscles, we burn it in our bodies. And the vast amount of fat is actually excreted as we use it and burn it to provide energy. It's basically converted into carbon dioxide and water. And so most of the fat that we take in is actually excreted out in our breath. That's just the reality. Now, fat then entered the blood, it's going around the body, it's being used, it's being burnt to provide energy. Some of that fat goes to the liver, and it's then converted into LDL, low density lipoprotein cholesterol, right? Which we all know and love. We get checked for it once a year, whatever, by our physicians, and that happens in the liver essentially, and then that is put back into the blood, and we use it. We use it to make cell membranes. We use it to make steroids. We use it to make other hormones. So it's very valuable. And probably if you go back multiple thousands of years when we were, wandering around having a different diet, our bodies kind of very carefully balanced the amount of fat that would come in, because it was probably quite a precious resource, how we used that, how we dealt with it, and that the level of LDL cholesterol in our blood was quite tightly managed. What happens today, because we tend to get more fat, is that we burn some, as I said, for energy. We use some in LDL circulating around the body. And then the excess is basically taken back up by the liver and destroyed. But the reason so many of us walk around today with elevated LDL, and new guidelines have come out, what level should that be? Everybody should be below 100. If you've got risk factors, get it below 70. If you've got a lot of risk factors or you've had a heart attack, get it below 55. It's difficult to do. And the way that we hook LDL out of our blood oftentimes is through the LDL receptor. And there is a protein that the liver produces called PCSK9. And PCSK9s basically reduce the number of LDL receptors in your liver. And so we make a PCSK9 inhibitor. If you use that medicine, it actually causes the number of LDL receptors on your liver cells to go up. You mop up more cholesterol, more LDL from the blood, your LDL level goes down. That's how those drugs work. We have a huge amount of data. It's been used in 9 million patients around the world. We have 40,000 patients worth of clinical trial data. It's highly effective, and it's been proven to reduce your risk of cardiovascular disease and heart attack, stroke, death. The LDL then that is circulating around can also be combined with a protein called ApoA. And ApoA is made by our livers. And so when you take LDL and basically you combine it with ApoA, you make the molecule that you very nicely talked about a minute ago called lipoprotein A. And, the reason that LDL is bad for you is because it tends to get taken up into our blood vessel, particularly our arterial walls. When it sits there over time, it's taken up by, everything comes back to inflammation. It's taken up by inflammatory cells, white blood cells, and kind of little mini ulcers form in, we all hear the term plaque, right? That forms in our blood vessel walls. And over time, that ulcer can kind of erode. And when it does, platelets come along and stick to it. And so you get a blood clot. And if that happens in your coronary artery disease, you're going to have a heart attack. If that happens in an artery in your head, in your brain, you're going to have a stroke. And that's why LDL is bad. The same is basically true for lipoprotein A. And there's been a huge number of studies now that have shown that people who have, different levels of lipoprotein A are more likely over time to go on and have a cardiovascular event. So that's why we think there is a relationship between it. High Lp(a), higher risk of a cardiovascular event. The reason for it is similar to LDL. It gets into the blood vessel wall, it can become oxidized over time. And so, what that tends to do is it forms plaques, you get inflammation in your arteries, you get calcification, probably enhances blood clotting as well. And so you can get this revved up, quite aggressive atherosclerosis, vascular disease. Now, as you say, it's been around for a long time. I think in many ways we've become particularly good over time at doing these association studies. Do large populations of people with higher LP little a, do they have more cardiovascular events? And as you say, the answer is yes, they seem to. Now, that can be associative. I have worked on several things in my career where you think for certain that this marker is high and it is associated with bad clinical outcome. If I bring it down, I'll reduce the risk of that clinical outcome. And it doesn't always play out. Okay. And so to find that out, we have to do large clinical outcomes trials. And we and others have now got a therapeutic. In our case, it's called olpasiran. It is an siRNA, so it brings down, basically turns off the gene, brings down the level of the protein, ApoA being made. And so in turn, lipoprotein, little a, comes down. It's very effective. It will bring it down by 95%. So basically floor your level of lipoprotein A. And now it's in some very large cardiovascular outcomes trials that we're doing. And the question that we are asking is, okay, if I can really bring somebody's LP little a level down, does that translate over time into a reduction in heart attack, stroke, the need for a revascularization event?
And I appreciate you laying the groundwork there. And again, it's an amazing history. Take us into the world of olpasiran because, as you were mentioning, this is a small interfering RNA therapy. So a couple of years ago, for everyone that follows the show, we hosted your former colleague Rose McLaughlin at Moderna that talked about RNA, but this is a little different in the sense that we're talking about interfering with an RNA sequence so a protein doesn't get made in the first place. And then there's some elegance here in the sense that, you've conjugated it with this thing called GalNAc, which makes sure it goes to the liver, and then there's some chemical modifications to make sure it doesn't get broken down in the bloodstream. Just talk about what the entity, so the new drug entity or the existing drug entity is, because it's kind of elegant in its structure by itself, and then we'll talk a little bit about what you found so far in phase 2.
Yeah. Well, look, I think that's a great summary. The beauty of siRNA is, as you say, it will align with a messenger RNA strand and it will essentially prevent it from being then made into a protein. It's synthesizable. You can modify it, as you say, so you can direct it at different tissues and organs. And there's a lot of interest in that. If you put GalNAc on it, it will get to the liver. And the liver obviously is the preeminent site of ApoA production. So it's perfectly directed. And they're very effective. I mean, as I said, with olpasiran, it will bring down the level of lipoprotein A, ApoA, by 95%, and it does that quite quickly as well. They seem to be safe. We're clearly testing that extensively in these clinical trials. In our case with olpasiran, we can administer it about every 3 months as well. So you get quite infrequent dosing. That's great for compliance and adherence to therapy. It's very effective. And so it really is like, would essentially pan out to 4 injections a year. And as I say, we know it brings down the level of this protein. Now the question is, can that translate into clinical benefit? And to do that, we have these very large, 10, 12,000, even bigger clinical trials. And one is called Ocean A outcome. And then we're also doing one called Ocean A pre-event. So we're looking at 2 different populations that we could talk about in a minute. But we enroll them. We do these globally. We go to hundreds of sites around the world. We work with hundreds of physicians. They enroll patients. They screen them. They sign their consent form. They come into the trial. And then typically what we do is we give them either a blinded placebo injection or we give them the olpasiran injection. And so neither the patient nor us nor the physician, nobody knows what they're on. We do the trial. We look for those clinical events. And at least for us, the endpoint that we are studying is there a coronary heart disease death? Do people die of a coronary heart disease cause? Do they have a heart attack? Do they need revascularization of their coronary arteries? So are they presenting to the hospital, for example, with severe unstable angina? They need to go to the cath lab or even go to a cardiac surgeon and be revascularized. So that would be part of the endpoint. So these are endpoint driven. They take a long time to enroll, and then you basically have to wait, and you've predetermined how many of these clinical events you need to see to have statistical power to determine if there's a true difference between placebo and your drug. And then you wait for these events to accrue. When you get that correct number, you then close the study down, unblind it, and you wait to see what the result was.
So again, phase 2, well tolerated. You mentioned this 95% reduction, durable, so persist for months. There was an interesting piece here, talks about some of the things. So the oxidized phospholipids on ApoB, that also goes down, which is extremely important, as you were mentioning, in terms of having the white blood cells come in and start that whole nasty process. And it also said there's some CRP and IL-6, not meaningful changes, but I don't know how important that is. But again, pointing out to the broader sort of systemic, thinking back to the early Burton career of, there's a lot of biology going on here. So, obviously a lot to learn, what happens when you flip one trigger. Take us into 2026 and Ocean A outcomes, because clearly, as you were mentioning, this is very large, and this is sort of, the hard cardiovascular outcomes, death, the important things that we care about. What's the schedule on this? Obviously, these trials take a while, but clearly, with Amgen behind it, and it's probably very well funded, and everything's in order. Let's talk a little bit about that and a little bit of what the secondary prevention study is all about.
Yeah. So as you say, Ira, that study, secondary prevention. So these are people who have had a clinical event,
Right.
and they had a heart attack. They have clear evidence of symptomatic atherosclerosis in their body. So they come in, they get enrolled, they get consented, they get given blinded study drug, and then you're waiting for those clinical events to accrue, and they get adjudicated to make sure that you kind of have a clear understanding. Was that a heart attack, or was it gastroesophageal reflux disease? These are important questions. So you adjudicate the events. So now we're waiting for those number of events to accrue. The pre-event study is basically the primary prevention study. So here are people who have some risk factors, but they have not had symptomatic atherosclerotic cardiovascular disease, but they do have high Lp(a). And then the question will be, again, if you bring down Lp(a), can you actually prevent those people from ever experiencing a cardiovascular event? That's a big population. It's clearly important because it has profound impact on longevity, and economics of that also are huge. These are typically tend to be a younger population. And so those studies are ongoing, and it's a waiting game. You wait for the events to accrue, and then you lock this study. And as you say, you've invested huge amounts of money. You've worked with hundreds and hundreds of people around the world. And then we wait there for our biostats colleagues to lock the database, to unblind it, to run the analysis. And literally you get an email, and in it is the primary output, and you open it and you're looking through it. I've had a few of those moments, and some of them are like, okay, this medicine, we just missed it. And some are like, wow, this is going to be a practice-changing medicine. And, I think that's the case with Repatha, and we've done large studies there, and it's continued to show its huge benefit. We really hope that olpasiran is going to do the same thing. But you have to do these big studies, and you have to definitively answer the question.
Well, it's going to be an exciting time, and clearly, obviously a lot going on with PCSK9 right now, but I'm looking forward to this one personally. And
Yeah,
so, obviously, as you're mentioning, there's a lot here, not just in coronary artery disease, but cerebrovascular, and then all the other things that people are pointing out that atherosclerotic plaque interferes with.
yeah,
I mean, looking out a bit, obviously, I mean, this is going to go great, and I'm excited for you. When you look at the cardiovascular field in general, else excites you? I mean, it's the Amgen working on it, but we profile things on the show. I'm in Philly here, and they're working on CAR T cells around the corner here at
mm,
University of Pennsylvania for plaque removal. A lot going on in sort of the recell, decell of the construction and bioprinting of new hearts in the lab. We got a little while to
yeah,
go on that, but what's the stuff that excites you? Thinking back to your PhD about, cardiomyocyte regeneration, where are we going? What are the things you want to
yeah.
see if we look a little bit over the horizon? Because a lot of exciting things happening, and just obviously love to get your perspective on it with your background.
Yeah, yeah. No, listen, it's a great question. I think very fundamentally, there's a lot we can still do in education. It sounds pedestrian and it's not that exciting, but think about the number of people who are actually on an advanced lipid lowering therapy, who are even being tested for their LDL after a heart attack. In some places that is not high. And so even getting into education and getting awareness around these things, I think is
Hmm.
key. And, we talked a little about AI and how we're going to hopefully be working more and more engaging with patients, with people out there in the world, helping them navigate their journey and get more and more health literacy. I think that's key. Um, I do love the idea of the use of stem cells, maybe CAR T therapies. Is there some kind of molecular unlocking that we could do that would actually allow cardiac myocytes to divide, in a controlled way? The problem with them is that they're actually very waxy, very rigid cells, and when to actually they're kind of log shaped if you look at them under the microscope, and they're beating. But to get them to dissolve that cytoskeleton, to dissolve that cell membrane and actually divide, just physically is extremely difficult. So therapies that could come along that could kind of push cardiac myocytes down that so they can actually divide, I think is huge. You talked about something I think is really key. Diseases have taken a long time to develop, and their pathophysiology is multifactorial. And one thing I really learned from the early Immunex days, where Immunex had tried to get Enbrel into heart failure because TNF alpha was a big driver of heart failure. And they could take TNF alpha away in that disease, but it had no impact because it's a chronic disease that's multifactorial. Sometimes you can't take away just one very isolated molecule and hope that a disease will improve. We have a medicine that's in development for obesity called maritide, and it is a GLP-1 agonist and a GIP receptor antagonist. And what I find really exciting about that molecule is its pleiotropism, because in the phase 2 studies that we've reported, we can bring down body weight by almost 20%, but it has profound impact on triglycerides. It brings those down by 28%, brings CRP down by
Hmm.
70%, brings down blood pressure by 11 millimeters of mercury. And we know that a reduction in blood pressure of like 5 millimeters of mercury is associated with a survival improvement. And it brings down HbA1c in the diabetic population by 2.2%. I worked on other diabetes medicines earlier in my career where a 0.7%, 0.8% reduction in HbA1c was seen as really profound. Well, this is bringing it down by 2.2%. That's almost 3 times. And so that surround sound that medicine could bring to cardiovascular disease, not only to bring down weight, and manage obesity. But the additional cardiovascular benefit, I think, is huge. And then, as you said, we have Repatha. We hopefully will have Olpasiran. We're doing those studies. We'll see how that pans out. But I think that portfolio of medicines and the impact it could have across that whole spectrum of different modulators of cardiovascular disease, different drivers of atherosclerosis, I think could be really, really profound, really impactful. So I'm excited about that.
Yeah, no, it's again, very, very exciting 2026 heading into 2027. Olpasiran, super GLP-1, obviously all the bispecific stuff that we were talking about on the oncology side. Anything else, Paul, that's exciting that's happening while we have you today? And then looking out a little bit, maybe as we get close to 2027, any other public-facing initiatives specifically for you, conferences, talks, other places that we may find you, and then anything that I missed while we have you today,
Yeah,
please.
yeah. No, that's great, Ira. Look, you said it, we're a broadly diversified company across multiple different therapeutic areas and diseases. Um, you talked with Angela, and she will have said a lot about bispecific T-cell engagers. And
Sure.
we have Imdelltra tarlatamab for small cell lung cancer that we're trying to bring into earlier and earlier lines of therapy. A previously very, very difficult disease to treat that's really been revolutionized by that. And we think that the earlier we can get in cancer progression, we can really bring clinical benefit. We have another one of these bispecific T-cell engagers now that we're testing in prostate cancer. It's called xaluritamig. I'm excited about that. Very promising early phase data. Again, now it's in late phase 3 testing. I'll be excited to see how that goes. We have a CD40 ligand inhibitor, basically dazodalibep for Sjogren's disease. When I was at medical school, we probably got 10 or 15 minutes on Sjogren's disease. What transpires is, thousands and thousands of people around the country, around the world with that disease. Very, very few treatment options, really debilitating. And we're excited about the possibility that that can bring. We have a Plisna that came in with the Horizon acquisition. It's a CD19 reducing agent given just twice a year. Very nice safety profile, has shown great promise in myasthenia gravis. So we want to continue to expand there. It's highly, highly effective. And, now we want to see other diseases. So I think, what differentiates Amgen for me is we go after the world's toughest diseases. Other people do as well, but we really, we are driven by our mission to serve patients. I think we have differentiated medicines that bring transformational improvement to the diseases that we go after. And we're committed to doing that more and more and more, as you say, as we go into 2030 and beyond. Cardiovascular, metabolic disease, cancer, immunology, rare disease, our biosimilars. It's a great portfolio. It's an exciting time to be at Amgen. And I think, honestly, it's a really exciting time to be in our industry. We have so many tools now, great medicines coming along. We're kind of realizing that promise that for the last 30 years, everybody's been imagining. And now with the huge compute power that we have as well to help shape that, I think the future's bright. I think we're going to be able to attack a lot of diseases going forward.
I definitely think so. I'm excited for you. It got me thinking back of, back in the 90s when, Amgen wasn't considered a pharmaceutical company then, right? It was still just a
Yeah.
big biotech company. And what we're talking about in 2026, but no, it's really amazing work. I wish you the best with all of it. I look forward to obviously Olpasiran making it through phase 3, but yeah, I really appreciate you sharing sort of this entire history with us and doing the arc of your career. But really impressive work. Again, for everybody out there that's going to be listening to this episode across the various podcast networks, or who'll be watching on the YouTube channel. Again, you've been spending time with Dr. Paul Burton, Senior Vice President, Chief Medical Officer at Amgen, doing really amazing things to shepherd forward this extremely broad research portfolio to save potentially millions of lives in the process. Paul, I want to thank you for, again, taking the time out of your schedule to come talk to us for a little while on this journey you've been on. Thank you for everything you do there for patients. Thank you for helping to create a better tomorrow for all of us. It's an awesome story, and I look forward to helping share it and continue to follow your work.
Yeah, super. Thank you. It's a privilege to be here.
Really great having you.